Okay, I'm Dr. Randy Fagin, and welcome to part 2 of our series on building your daVinci surgery program. It's a 4-part series. Our first part talked about reducing variability. This part talks about using parallel tasks. I would encourage you to watch them in series 1, 2, 3, and then 4. They build on one another. So if you haven't watched number 1 yet, I'd encourage you to go back and watch that. This section is going to talk about using parallel tasks. So how do parallel tasks help us to build our daVinci surgery programs? Well, there's 2 things that are essential when we talk about parallel tasks: task conversion and task overlap. Just these 2 topics, that's all that we need to learn. On the task conversion end, there are 2 kinds of tasks that happen in every single operating room, no matter what's going on. There are things that are called internal tasks. These are things that must be done while the system is down. So for an operating room, this would be mopping the floor, changing the sheets. These are things that are done while the patient is out of the room, while the system is down. If we transferred this over to pre-op, this would be the things that you do to prepare for getting the patient into the room. Patient's not back in the room yet. You haven't pulled them from registration yet. The room is empty. That's what you're doing while the system is down. External tasks are those things that can and should be done while the system is active. So for that same operating room, an external task would be a nurse charting something in the computer or in her paper chart. You can do that while the operation's going on. For the pre-op folks, this would be putting an IV in, while you're kind of interviewing the patient. These are things that are being done while the system is active. Our key is we want to take things that are traditionally internal tasks, things that are done out of heritage because it's always been done that way, and say, you know what, robotics is a little bit different. We don't need to do this stuff while the system is down. We're going to do it while the system is active. We want to actively convert internal tasks to external tasks. 4 examples of things that are internal tasks traditionally for robotic programs that should be external tasks: setting up the back table, draping the robot, undraping the robot, and breaking down the back table. Things that are traditionally done while the system is down. Most hospitals will set up the back table, then drape the robot, and then call for the patient. Not very effective, not very efficient. On the same end, they will let the patient leave the room and then they'll break down their back table, break down their robot. These 4 tasks, if you do nothing, if you just walk away from this video right now and you do just those things, if you can just take those 4 tasks and do them while the patient's in the room, you will significantly improve the efficiency of your operating room, and it will bolster your ability to grow your daVinci surgery program. How about task overlap? Most hospitals do things in series. And this is kind of out of tradition. We do it to kind of help each other out. We want to work together as a group. I call this 8-year-old girls basketball. If you've never watched 8-year-old girls basketball, I would strongly encourage you to watch it. It is an absolute riot. I had the privilege, it was a load of fun last year, and I'm doing it again this year, of coaching my daughter's 8-year-old girls basketball team. Tons of fun. So if you've never watched 8-year-old girls basketball, here's how it works. There are 8 girls on the court. There are 4 on one side, 4 on the other. It starts by one of the girls kind of passing the ball to her teammate. As they start to dribble it down the court, all of the girls, the other 7, clump around this one girl. It's this mass of girls. It looks like a rugby match. In fact, sometimes they're actually on the floor kind of scuffling around. Eventually the ball kind of squirts free. Either it bounces off somebody's foot, or some girl goes dribbling and finally actually makes it out of the pile, or usually she just is holding the ball and she starts running with it like a football, and the parents are yelling, "Dribble!" And she makes it out, and it takes a second or 2, and the other girls realize she's gone, and they then chase after her, and then you have a new clump of girls, and this kind of clump and move thing happens all the way down the court until eventually they get close enough to the net that somebody launches the ball up, and the parents cheer, and this goes on for an hour and a half. This is our operating rooms. This is how we function. Think about it. You've got 4 people who work together to set up a back table. Scuffle, scuffle, scuffle. And then the ball squirts free. And then you've got 4 people who are draping a robot. Scuffle, scuffle. And then the ball squirts free. And one person goes to get the patient, one goes to get a smoke, one goes to eat, and one goes to hang out and do nothing. It's a horribly inefficient way of actually getting ourselves prepared for a robotic case. And you can't build a program based on that. So if we change that scenario, if we say we're going to do things in parallel, we're going to say, you know what, for robotics, there isn't a whole lot that needs to be done by more than one person. So we're going to assign different tasks to different people. And we'll say one person drapes the robot, one person sets up the back table, one person goes to get the patient. And even though those individual tasks may take longer one at a time, globally you get done sooner. If setting up a back table took 5 minutes with everybody and 10 minutes by yourself, and draping a robot took 3 minutes with everybody and 5 minutes by yourself, and getting a patient's 10 minutes. It takes 18 minutes to do all of that as a group because you set up the back table, then you drape the robot, then you get the patient. If you were to assign individual tasks and do them in parallel, even though setting up the back table takes longer and draping the robot takes longer, you're done in 10 minutes because the longest time it takes anybody to do things is 10 minutes. So doing things in parallel can significantly improve the efficiency of what you do. If at the same time you can take stuff that's done in this red zone, things that are done while the system is down, and say we're going to do them while the system is active, that will significantly reduce your turnovers, and it will improve your ability to drive more cases per day. I've done nearly 3,000 daVinci cases. I've never in my lifetime had a turnover of more than 20 minutes. We were usually 7 to 12 minutes. And it's because we just didn't have that much to do during the turnover. We didn't have a team of thousands. We didn't have hundreds of sets of equipment. It really was just not having a whole lot to do during the turnover. So let's talk about that. Let's take it step by step. There's a flip chart, and if you don't have this flip chart, you can ask your intuitive surgical representative for the operating room efficiency flip chart. And it goes through step by step how we can use parallel tasks to improve the efficiencies in our operating rooms. And at the very top here, you'll see this trigger point. And these are things that happen in every single robotic case, regardless of what's being done. There's nothing here about a prostate or a uterus or anything. And at that trigger point, it'll tell you what each of the people in the room are doing. So our first trigger point here is setting up the back table. What's happening? Well, your circulator should be getting the patient, your scrub is setting up your back table, and your assistant is setting up the back table. When I say setting up the back table, I want to define this first of all and say this does not mean that your back table is set up. This means that it's a pile, a mound of stuff, like a Foley catheter is teetering on the top, and if you don't grab it, it's going to slide right off onto the floor, and you'll have to get a new one. When it's just a mound of stuff, your circulator should leave to go get the patient, because we know, remember, 10 minutes to go get a patient takes about 10 minutes to get your back table set up. So when they come back into the room, your back table should be just about set up. Patient enters the OR. What happens now? Well, we're positioning the patient, we're inducing them, we're intubating them, and guess what? The scrub is draping the daVinci cart. Oh my gosh, you're draping the daVinci cart and the patient's in the room. I mean, whatever, it's not a big deal. I mean, seriously, from when a patient enters the room until when you actually need that stuff, it's like 20 minutes. I mean, you have to get the blood pressure cuff on them, you have to get their vitals, you have to oxygenate them, you have to induce them, you have to intubate them, you got to prep them, you got to drape them. There's just a boatload of stuff that needs to get done. Plenty of time to drape your robot. Patient's draped. Okay, so first of all, your critical point here is, so our matchup should not be patient enters the room and everything is ready. The critical point should be patient is intubated and everything is ready. So once the patient's intubated, our back table is set up, our robot's draped. So now that the robot is draped, we now drape our patient and we start our procedure, and we connect things, we connect the bovie, the gas, we start doing our surgery. The important point here is we want our team members to anticipate what the surgeon does. Remember, surgeons, we are not spontaneous, we are very predictable, we do things the same way every time. So, if we use the bovie first and then the gas, make sure you connect the bovie first and then the gas. Even if the bovie is further away from you, if it's geographically inconvenient, if that's what we use first, walk across the room and plug that in first, because that's what we need first. So always anticipate needs. If you have to wait for the surgeon to say, can you this, can you that, all those little 10, 15, 30-second delays add up. And it can be literally add 20, 30 minutes onto the case of just people responding to the surgeons. Okay, ports are placed, the robot is docked, the cart moves in, the instruments are inspected. The important thing here is, you'll notice under circulator, after she moves the cart in, she begins her paperwork. At no point in time prior to this should the circulator even motion towards the computer or towards her chart. Because, listen, this is not an open case. Open cases are a marathon. You're retracting stuff, you're suctioning stuff. There's sponges that need to come out. They got to get pulled. You got to check the EBL. You're stuffing in those little plastic things in the wall. There's stuff that falls on the floor. You got to take it to the flash. That circulator is actively involved in the case. For a robotic case, Once you dock that robot, you're chilling. I mean, folks are kind of hanging out. There's not a whole lot to do, especially for the circulator. So you're going to have, circulator, at least an hour, give or take, to fill out your paperwork. There is no computer program on the planet that is so complicated that you can't fill it out in an hour. So do not sit down at the computer. Do not sit down to chart things until that robot is docked. Once it's docked, you've got a load of time. Use that time. Surgeon's off the console. When he stands up from the console, he is saying to the world, I am done using this robot until there is a new patient with a new armband on this table. So once that happens, then you should roll the robot back. You should undrape the robot. You should not just undrape it, but you should undrape it and put the drapes into the garbage. If the garbage is full, guess what? Tie the garbage up, put it by the door, and put a new garbage bag in. I mean, think of it like your house. Okay, for those of you who aren't married, I'm going to give you a tip here. So as a husband in a relationship, I have learned, and it took me a little while to learn this. I'm slow, but I'm trainable. It took me a while to learn that if the garbage is full, number one, don't add it on top of the pile. That's an absolute no. You should empty the garbage, tie it up, take it out into the trash, into the garage, but don't stop there. If you stop there, you may as well have not done it at all. You then need to go back in to the house and get a new garbage bag and put the new garbage bag into the garbage container. So think of your operating room as your home. You live here, okay? So if the garbage is full, goodness gracious, don't take the drapes off and just leave them on the floor. Pick them up off the floor. It's kind of like, one of your kids when they get out of the shower, if they just drop their towel on the floor, you're like, seriously? The hamper is right on your way out of the bathroom. Don't leave it on the floor. So take the drapes off. Don't leave them on the floor. Put them into the garbage. If the garbage is full, tie it up. We're preparing for the end of the case here. We are undocking the cart. We are undraping the robot. As the surgeon is closing the wounds, the team should then be, clearing off the back table. So by the time the patient actually leaves the room, the back table should be empty. It should be naked. There should be nothing on it. The garbage should be tied up and sitting in the corner, ready to go. When the patient leaves, all this stuff should leave with them. So when you have to turn over, when the patient's gone, all that's left to do is, mop the floor, wipe the counters down, change the sheets. Not that much. So task conversion, task overlap. We want to do things traditionally done while the system is down and find ways to safely do them while the system is active. Task overlap, we want to assign different people different tasks. So two people should not be helping each other out unless it is critically necessary, and most of the time it's not. We want to have different people doing different tasks so we finish all of our tasks simultaneously. Okay, that's parallel tasks. We will be moving on to leadership and communication and performance enhancement cycle. I'd encourage you to watch all of these in series 1, 2, 3, then 4, and I'll look forward to seeing you for number 3.